The Healthcare Labyrinth Podcast is back for another episode. Join Marc S. Ryan, a veteran health plan and health technology executive, as he explores the world of healthcare.
Welcome, everyone, to this edition of the Healthcare Labyrinth Podcast. My name is Marc Ryan. It's a pleasure to be hosting this podcast, and thanks to everyone who's listening in. Today's topic is just going to pick up a little bit about where we left off in last week's podcast. Last week, we sort of had part two of a two-part election year podcast. On 6/7, the podcast dealt with basically telling you a little bit about what was happening in the presidential and congressional elections and why I thought healthcare might actually play a role in some of the swing counties, districts, and states. And then on June 14th, we had my modest proposal for healthcare reform, where I sort of gave you some facts about our healthcare system and my proposal for what should be done. And it basically revolves around three main tenets. One, affordable universal access is extremely important to reduce costs and get everyone upfront care. Number two, price reform throughout our system across lines of business. And third, pivoting from utilization management and prior authorization to care management. And I believe there's so much more that can be attained in savings and quality if we do that pivot to care management, which would feature wellness and prevention from our obsession with prior authorization and just gatekeeping services up front. While that's important and will always be a part of the system, again, we're obsessed with that, and there's more money and better outcomes if we care manage. So what we're going to do over the next 3 weeks is we're going to take my modest proposal for healthcare reform from the June 14th podcast, and we're going to do a 3-part series. This will be part 1 of digging deeper into my proposal for healthcare reform. What I thought I would do today is start with the issue of price. I think all three of them, care management, price, and affordable universal access, all have to go together, but let's take them apart one by one. And today, I think, again, we'll start with price. As usual, we'll be taking a couple of breaks, so we'll try and break up the podcast along the way as well. So in my May 27th, 2024 blog, I argued that we need to fundamentally tackle price in the system. With limited exceptions, price in our healthcare system is not based on any semblance of cost. Let's take a look at hospital prices as one example. We have so-called charge masters that hospitals keep that do not represent costs in any meaningful way. Reimbursement in Medicare and the commercial world is deeply discounted from these charge masters. Hospitals keep these charge masters at exorbitantly high prices simply to have leverage in commercial negotiations and to perpetuate the myth that government programs radically under-reimburse. This may be the case to some degree in Medicaid in some states, but it is not accurate overall. The same system exists within the broader provider community, which has billed provider charges that substantially exceed real costs. The huge price tags that providers put on their services hurts in a number of ways. Let's take them apart right now. So first, by nature, these price or charge masters or billed charges mean unreasonable costs in the system. Most provider charges are well above reasonable costs. Second, it leads to greater inflation. Providers tend to inflate their exorbitant prices each year in an effort to drive negotiated prices. Inflating high prices tends to force negotiated prices up. Let's consider a simple illustration here. If a provider has, say, a $100 billed amount for a service and inflates that by 7% per year, the provider asks for most or all of the $7 in negotiations each year. If that fee is reimbursed at 50%, Inflation on that amount is $350, but plans tend to have to cover a piece or all of the other $350 to satisfy providers and meet network adequacy. So it's a false way of negotiating. While true inflation hits the system, much of the increase is based on this flawed pricing system from year to year. Third, such a system also promotes inefficiency across the board. In this kind of markup system that isn't based at all in fact, there are really no incentives that exist in this system to reform, to make things more efficient on the provider front. That's why we hear all the time about bloated hospitals and many bloated providers as well. Last, high prices also force up out-of-pocket costs for Americans. High prices force plans to demand more in premiums, but also in deductibles and cost sharing. As prices go up from year to year, they sort of move costs over to those deductibles and cost sharing, and each and every year then that individual that's paying that out-of-pocket cost tends to pay more and more and more. So it's a burden not only on the healthcare system overall, but on everyday Americans who find it very difficult to afford premiums in the first place, much less deductibles and cost sharing. So in the 527 blog, I argued we should adopt what's known as a uniform national and/or regional model for healthcare pricing as other nations do. This would be across all healthcare lines of business. This would be a direct response to the effects of hospital monopolies, again, these exorbitant price masters, and high rates in general. This also would bring a great deal of price transparency and stop surprise billing, which would be very important outcomes as well. This proposal works in and out of the United States already. Let's look at the rest of the developed world right now. As you know, we talk a lot about there are three types of systems: socialized medicine, single payer, and private affordable universal access. In all of these countries, an all payer and all line of business rate system exists with uniform fee schedules. This is not unlike also what is done in the traditional Medicare fee-for-service program, which helps private plans drive better overall rates in the system in Medicare. Some Medicaid states as well have experimented with provisions that require good faith negotiations to occur between health plans and providers. If such talks fail, a rate tied to prevailing reimbursement or a low Medicaid fee-for-service system rate is automatically adopted. So again, this concept of uniform pricing is not outlandish. It's practiced in other developed world countries, and we have some semblance of it in Medicare and in some Medicaid states. I often turn to the Bipartisan Policy Center for looking at reasonable reforms in the healthcare world. And the Bipartisan Policy Center suggests that exorbitant hospital rates in uncompetitive areas could be tackled by pegging maximum rates to either the average Medicare Advantage rate in a given market or the commercial payment in a competitive market. As well, the center would bar anti-competitive contracting standards, such as having to contract with every provider owned by a hospital or system rather than specific providers the plan needs. How much could proposals like this ultimately save, especially if we adopted uniform rate setting? Well, it's a little bit hard to tell, but the Urban Institute actually did an interesting study that sought to sort of give us a feel for what savings might be. It's not exactly on par, but somewhat close. So what the Urban Institute study did was it looked at what would costs be if there was a public option in the exchanges. And the exchanges then in that public option plan used rates that were pegged to Medicare rates or just above it in some scenarios. Now, I want to stipulate that I'm not a fan of creating a public option in the exchanges. But what this study sort of showed is what the cost-saving impact is of essentially having commercial rates migrate to Medicare rates or something just above that in certain scenarios. So what did the Urban Institute found? Well, it found that having a public option with these rates for just the non-group markets, sort of the individuals, did little reduce costs or the uninsured rates, because as prices go down, more people can afford insurance. But it did save substantial sums if group market employers chose the public option for employees. If some employers took advantage of this public option with these rates that were pegged more like Medicare, the uninsured rate could drop by up to 1.7 million, and employers would save up to 143 billion per year. If all employers were in a public option plan, the uninsured rate would drop by up to 1.6 million, and employers would save up to 224 billion per year. All employer scenarios had add-ons only to the Medicare rates. So basically what it's showing is that if we did migrate price in the commercial world down to Medicare, there is 143 to 224 billion in savings to be had in price alone. Now, many would argue that that's way too far down, that Medicare may or may not be the most appropriate rate in a given area, but nonetheless, it does show you how big the savings are and how much more commercial is paying because these exorbitant charge masters and build provider rates than what Medicare does charge today. So again, to reiterate, I'm not endorsing a public option in the exchanges, or do I think it's a good idea? But the study does show how an all-payer and an all-line of business rate system with uniform fee schedules would save a great deal of money in the healthcare system. From here, what plans would do if they adopted something along the lines of uniform price policies across lines of business, health plans could tweak those rates, including adopting value-based care payment models or perhaps paying certain trusted providers more. They would largely, then health plans would compete on quality and satisfaction. Administrative costs would drop dramatically with uniform rates. Right now, there's tens of millions, if not hundreds of millions of dollars in wasteful costs because we have so many different prices between payers and hospitals that need to be adjudicated along the way. Uniform pricing would take away all of that disparate pricing. It would take it away between regions of the country that we see often, within regions of the country, which we also see, between hospitals when a payer is making payments, between payers even to one hospital, and even within hospitals and payers that can have very different rates, negotiated. So there is just a tremendous administrative burden in all of these different kinds of rates, one-offs with each plan and hospital and plan and provider. That could be taken all away with this uniform system. It would save billions and billions of dollars in terms of net outlays for services, but it would also save billions and billions of dollars in reduced administrative costs. With that, we'll take our first break.
The Healthcare Labyrinth is no ordinary website. It features news and commentary from one of the nation's leading healthcare policy and technology experts. Marc Ryan combs the internet for the latest healthcare news and publishes a news feed each weekday with summations and Marc's insights. Twice a week, Marc publishes a blog to go deep into a current issue. And of course, Marc hosts a podcast each week to delve even further. All of this is available at healthcarelabyrinth.com. Visit each day for the latest happenings in healthcare. As well, learn more about Marc's book, The Healthcare Labyrinth, at the website. That's healthcarelabyrinth.com, your go-to source for healthcare news.
Welcome back, and we hope you're enjoying this episode of the Healthcare Labyrinth Podcast. We're talking about price reform as a fundamental part of healthcare reform. We sort of just reviewed my proposal related to how we need uniform pricing, and we reviewed a couple of studies and recommendations on this issue and determined how much this could save in certain types of scenarios. And it is a lot of money, both on the administrative and on just the regular healthcare services front. I wanted to sort of close out our discussion related to sort of general price reform by just asking the question, if you think my proposal is too big and too fast, is there some sort of other modified proposal out there that could still save dollars and bring us down the road of price reform? Well, if you do think my proposal is too big and a little bit too fast, you can look at another prominent healthcare academic reform group called the 1% Steps for Healthcare Reform. They have a proposal that sort of starts the process of reining in very high prices in the provider world. And it sort of starts with the concept of an outlier scenario. So it really seeks to take away the highest outlier types of prices out there, and then perhaps might move, farther down the road toward what I'd like to see on a comprehensive basis. So 1% Steps for Healthcare Reform notes that over the last 3 decades, provider markets have become increasingly consolidated, and prices for care in the commercial line of business have steadily increased. Well, that's absolutely true, and we talked about that a little bit before the break. Its proposal could save 5.7% of commercial healthcare spending, or 1.8% of total healthcare spending, not counting annual inflationary cap savings, which they'd also like to do. Their proposal saves about $68 billion of commercial healthcare spending in roughly current dollars. Now, 1% Steps for Healthcare Reform proposes the following. At the local market level, they want to introduce what's known as backstop price caps for in-network and out-of-network rates, which would bar prices above the lower of A, 5 times the 20th percentile of local prices, or B, the 75th percentile of such service market price percentiles nationally. They also want to introduce price growth regulation that limits provider price growth and allows higher growth caps for relatively cheap services and lower growth caps for more expensive providers. So this would be something along the lines of what was introduced in Medicare drug price reform, which essentially caps annual inflation rates. They also clearly spell out that they would need to have appropriate federal and state reporting to monitor and enforce the policy. The proposal says that physician office visits at the median 20th percentile commercial price approximate Medicare reimbursement. So that's pretty important. The median 20th percentile of inpatient payments is approximately 133% of Medicare reimbursement. So those hospital payments are a bit higher. The price caps would be around 5 times Medicare, which in general sounds very generous. The regular market doesn't have that. About 4.5% of all service cases would be impacted, and 84 or so percent of providers would be impacted in their areas. So again, what the proposal does is take the excess out at the very top end. I would argue more needs to be done to drive commercial provider payments down. So the proposal is not that radical as a start, in my opinion, but it still saves a great deal and would mark the beginning to bring prices down in the commercial world that are clearly exorbitant. Let's talk a little bit now about drug price reform, because that's a little bit different than what you think of as traditional hospital and other provider payments. So we also have to tackle drug price reform. While I'm not going to go into great detail here, I wanted to just mention some of the concepts. Again, a lot of this taken from my Healthcare Labyrinth book. So number one, we need patent and Food and Drug Administration process reforms, including generic and biosimilar promotion. We need streamlining, reforming, and adopting better price transparency in the drug supply channel. We need elimination of rebates and or requiring all reductions from gross price be passed through at the point of sale. We need drug price reimbursement reforms, how we calculate AWP, how we calculate average sales price for medical drugs, all need to be looked at. We need pharmacy benefits manager reforms. I'm a general defender of PBMs, but there are some very unseemly practices, including barring spread pricing that we need to do and requiring transparent models. And lastly, I really believe that we need drug price negotiation and perhaps international reference pricing across all lines of business. The Inflation Reduction Act's Medicare drug price negotiations, I think, provides a great foundation that mirrors what other developed countries do for their entire systems. So we should model what we do in the rest of the nation after what we are doing modestly right now in Medicare drug price negotiations. So that is a little bit more about a first 1% steps for healthcare reform and second, drug price reform. We're going to take another quick break right now, and we'll come back to sort of conclude our podcast.
Lilac Software is proud to work with the Healthcare Labyrinth website to educate people on the healthcare system. At Lilac, we believe transparency is so important in healthcare. The healthcare system is opaque, and Lilac is trying to bring clarity to data and unleash the best member care, reduce costs, and improve outcomes. Our cloud-native payer platform revolutionizes data insights and analytics. Plans have all the data they need, but in silos locked away in point solutions. At Lilac, we solve the data fragmentation problem and help plans turn complex data into actionable insights, leading to greater operating leverage, tight cost controls, and healthier members. Health plans can improve STAR scores, reduce medical expense, drive revenue, and more. Quite simply, with Lilac, you can drive better business and health outcomes. Learn more at lilacsoftware.com.
Welcome back, and we hope again you're enjoying this episode of the Healthcare Labyrinth Podcast. We've been talking about price reform, part one of an in-depth series related to my modest election year proposal for healthcare reform. And so we're just going to conclude here really quickly with some other related reforms that I really believe need to be implemented along with price reform. And so first, I do think we need broad price transparency regulation. We've taken some baby steps in terms of hospital and health plan price transparency reporting. We've had various levels of implementation and compliance, but we really need more and more of this. My theory is that based on what we have today in technology, we have people every day looking at price and combining price with value, perhaps how much better a given product is. And we're making decisions in all walks of life on the issue of price and value. And so there's no reason why we can't get to that level in healthcare too. But first, we need really broad price transparency regulation and an agenda on this. We've made some baby steps only. We also need to adopt site-neutral payments. This would help move toward uniform price as well. The same service should be paid the same rate across all places of service if that service can be performed in various places of service. So, for example, place of service 11 is the physician office. Place of service 22 is outpatient hospital. Place of service 24 is an ambulatory surgery center. We need the ability to price the same across all these places of service. Hospitals should not be allowed to have higher rates or charge facility fees for services that can be performed in ambulatory settings, physician offices, or potentially at home as well. We need to expand value-based payments and care. In the provider world, this is really payment-based and thinking about how outcomes are factored into payments for services or bundles of services. In the health plan world, we sort of have value-based care, global and partial risk funds, or maybe capitation at the very beginning. But all of these kind of things really need to be placed into the system to promote efficiency as well as to promote outcomes. We really need to invest a lot in consumerism and personal responsibility. I mentioned broad price transparency when that could be. That's a small part of consumerism and personal responsibility. But we need to include awareness of using the most appropriate site of care. While we want to maintain reasonable cost sharing so we do not create barriers to care, to me it is not unreasonable to create a system where a low-cost quality provider or drug is covered with reasonably modest cost sharing. However, if you choose another provider within a place of service or a more expensive setting, that might mean you pay 100% or a large portion at least of the difference in the cost. This is what is referred to as reference pricing. And while we have to be careful about implementing it, reference pricing is something that could promote consumerism and personal responsibility. It essentially places an upper limit by a payer, what that payer would reimburse at, with the consumer covering the additional amount. You have the freedom, if you have transparent pricing, to decide to pay more than what that payer is willing to pay. And it largely will be based on quality, or it will be based on a place of service, as an example. Interoperability and data sharing between providers and payers is also very important. I think that touches on price and cost as well, so I mentioned it here. We also need reforms to rein in aberrant provider practices, which is a big part of the up to 25% of healthcare spending that is wasteful, abusive, or fraudulent, known as FWA, or fraud, waste, and abuse. We also need provider benchmarking, where providers are analyzed for both their efficiency and their outcomes. So I believe all these related reforms sort of support what would happen if we were able to comprehensively reform both price in the system in general, as well as drug price as well. With that, that's part one of diving deep into my modest election year proposal for healthcare reform. We'll do part two and part three in the coming weeks. We hope you enjoyed this. And with that, we'll end this podcast, and we'll see you on the next Healthcare Labyrinth Podcast. Take care.
Thanks for joining Mark and the Healthcare Labyrinth Podcast. Go to healthcarelabyrinth.com each day for the latest healthcare news. See you next week on the next Healthcare Labyrinth Podcast.